Good afternoon, everybody, or good morning to our American audience. My name is Simon Ramshaw. I'm Managing Director of Erchonia Lasers Limited, which are a subsidiary organization of US-based Erchonia Corporation. We handle our interests for Europe, the Middle East, and Africa. So I'd like to welcome you all on this roundtable event, How to Protect Your Brain. It's an event we've looked forward to putting on for a while now, but due to availability, this was the earliest date we could get started. A lot of you have already been on our webinars, and I hope you've enjoyed them, as well as found they were very valuable from an educational perspective as well. Slightly different panel today, so I'd like to introduce you to everybody, but I'm going to keep it brief because we have had quite a few questions that have been sent in. So everybody will recognize Dr. Trevor Berry there, who came on our last round the table event. So welcome, Trevor.
Good to be back, Simon. Thanks for having me.
Good to have you. Trevor's a neurochiropractor from the Arizona Chironeuropractic Center, and he's been very involved with Erchonia for years and with low-level lasers for years. And we're honored to have you on, Trevor, so thank you for that. We've also got Dr. Jake Cooke down the bottom, if you'd like to give a wave, Jake. Jake's a neurochiropractor, and he has the Neuromuscular Center down in Woking. So welcome again, Jake. He's become a bit of a mainstay to our neuro-related events, and it's very good to have you back.
Thanks, Simon.
And I would also like to introduce you to some of you who may remember her from the last neuro webinar we did, and Mrs. Sanna Holmgren, who should be probably in the top left-hand corner. Sanna's a neurotherapist from Falun, which I probably pronounced wrong. It's a couple of hours north of Stockholm. Yeah, you've done it well. So welcome, Sanna.
Thank you. Thank you for having me.
Sanna's been involved with Erchonia for quite a few years, and she works very closely with Arch of Scandinavia, who's our Scandinavian distributor. And yeah, she's lectured for us before at our Barcelona event that we did for partners, and is very knowledgeable in this field as well. So we'd welcome Sanna. And last but not least, we'd like to welcome our own clinical consultant and owner, podiatric surgeon of the Middleton Foot and Laser Clinic, Mr. Robert Sullivan. Welcome, Rob. Rob, as many of you are aware, has been involved with us for quite a while. He is responsible for our training program in Europe and Middle East. And he himself has run quite a few educational webinars as well. And I think that lots of people have found it very good to get Rob's insight from a non-chiropractic or non-physiotherapy perspective. So I think we've got a fantastic panel. And on that note, guys, I'm going to start the PowerPoint presentation. We have some videos to run. Actually, sorry, guys, before that, everybody will be well aware that down the right-hand corner, there is a question section. So if you have any questions, we'll keep looking down and we'll ask the panel towards the end, or if it's pertinent to each question as we go along. And also, if there is a question that you'd like to ask verbally, you'll notice a hand signal on the panel. If you just click on that, and it will raise a hand, and we will unmute you and ask the question. If you don't put the hand up, we'll obviously just presume that you have no questions to ask. So on that note, guys, I'm going to play the first video, which is from Sarah Wilkinson, who's a neurophysiotherapist from Neuropathy Works up in Bolton in the UK. So we'll get going with her question.
Hi guys, my question today is with regards to multiple medication and use of the laser. So a lot of my patients are on take multiple medications to manage things like pain, spasticity, anxiety, and depression. And obviously, with a lot of the medications that they're taking, there are side effects such as fatigue and drowsiness. This obviously isn't very good when I'm trying to improve mobility, improve stamina, and improve functional outcomes. So I'm just wondering whether you have noticed a difference through your experience of treating people with the laser on medication and whether people, as a result of using the laser, have reduced the amount of medication that they're taking, and also as well if there's any evidence to support this. Thank you.
Okay, thanks for that, Sarah. Trevor, would you like to lead us off?
Yeah, that's an interesting topic, because first off, with the audience here, obviously making sure everyone stays in their own scope of practice parameters there as far as medication alteration and whatnot. But I think that, just from using examples, for example, if you laser and do thyroid protocols, you will increase output of thyroid hormone. So when we're doing those kind of endocrine type cases, I am monitoring labs to make sure that we may be able to titrate or draw down certain medications. Thyroid is just one example. Diabetes medications like metformin and whatnot, you will find that the patients will be able to start to draw back or come down on their medication levels. Blood pressure medication, so that's we're always monitoring those objective biomarkers, blood pressure, lab work, things like that, so that you can navigate accordingly to that. Another big one is obviously the neurochem stuff. When you start to alter serotonin output, GABAergic output, we'll get more into that as the morning goes along. But so yes, in short, you will see alterations in medication levels that are needed, and it's just important that the doctors are kind of monitoring that as they go.
Yeah, that's great, Trevor. Thank you. Jake, do you want to go up next, please?
Yeah, so my setup isn't as sophisticated as Trevor's, so I'm not doing blood work, I'm not advising patients on medication. The big one is obviously pain meds. So all your migraine patients, that's a big one, the ones who are using all their sumatriptan and all those those heavy medications. So I find that, for me, I suppose it sounds a bit simplistic, but you're basically just have a automatic questionnaire that goes out to them every 2 weeks, and they on their first session, we choose the symptoms they can put in. They scale it from 0 to 6, 0 being fantastic, 6 being terrible, and then I just check that every 2 weeks to see has anything, do they start reporting any side effects from medication. So it'd be classic, like you with your heart medications and stuff that are to do with lowering blood pressure. If a patient starts complaining of symptoms that sound a lot like low blood pressure, standing up, getting dizzy, stuff like that, then the simple conversation is just say, go back to your GP, go back to your neurologist, and ask them, are those medications still the right ones? Yeah, I don't do thyroid testing, stuff like that. That's maybe somewhere I should go, but simple stuff, look for the side effects that start coming out if their medications are suddenly too strong.
Okay, thanks for that, Jake. Rob Sullivan, would you like to come in now, please, if you have any experience on this field?
I think for me, we have a form that people fill in when they come to clinic first, and we would very much be aware of the medications that they're on. If I'm taking them into laser for laser therapy, I would always say to them at the beginning that we're going to monitor you, we're going to watch you, but this will change the way that your medications are going to interact with you. You're probably going to need less medications. I'm not going to adjust their medication. I'm going to send them back to their general practitioner unless it's a medication that we gave. I think always we're working with laser, we're working with electromagnetic energy transfer. We're working with something that basically creates energy within the system and allows the body to go into a restorative, regenerative mode. And the result of that is global. And yeah, that's going to affect pain meds. It's going to affect blood pressure medicines. It's going to affect pretty much all the medications that are out there. But unless we're actually the prescribing attendant, it's not within our remit to actually change or alter those medications in any way. So I would always work very closely with the patient, very closely with the general practitioner or the specialist, and I will either ring the specialist myself or I will send them back to the attendant for modification of medications if need be.
Great, thanks for that. You were breaking up a little bit there, but I think we got the gist of what you were saying. Sanna, do you have anything to add to that?
I like this kind of questions because it's close to my heart. This kind of disorder with anxiety and depression and other disorder that actually comes from your interoception. And interoception is one of the systems that your brain uses to handle you in the environment you're in. We have proprioception, that is spatial awareness. We have exteroception, efficient motor control, that meets movement goals. And then we have interoception. Well, interoception is a process which we receive and access and evaluate internal body signals, monitor and predict autonomic needs. So when your interoceptive system works properly, it makes us to understand that something inside our body is in balance and that we must change and do something about it if we actually feel something about it. For example, if you freeze, you go put on a sweatshirt. If you are hungry, you go and eat. But at the most basic level, your interoception answers the question, how do I feel? And studies show that a mismatch in your, or a dysfunction in your interoceptive system, sending weak signals to few signals, to many signals, or bad signals, or wrong signals, plays a key role in chronic conditions such as anxiety or depression, or as we have a question in front of us, I think, about sensory processing disorder, in the same loop. So interoceptive is your how do I feel good feelings, and the interoceptive feelings are centered in insular cortex. And insular cortex is a lobe that actually is behind the temporal lobe, and insular cortex is responsible for integrating vision, vestibular, and movement, so they work together. And if you're not feeling good, as in anxiety and in depression and other kind of similar diseases or symptoms, do you actually have a mismatch in insular cortex? So if we see this as a bigger picture, if we see how we can treat this and not chase for symptoms and chasing pain, we can actually change the whole system. And how do we do this? How do you change the interoceptive system? Your interoceptive accuracy actually comes from how good your organ works. So you need to start with your organs. Look for dysfunction, always have a protocol for the organs, probably need food and nutrition. Organs means vagus nerve, because it innervates the organ, and vagus nerve is also responsible for sending the information from the brainstem through the organs to the insular cortex. Vagus nerve originates from the brainstem, the lower part of the brainstem, medulla. So you have cranial nerve 9, 10, 11, and 12 to work with. And we also have the parasympathetic nervous system there. So it's a huge area to work with vagus nerve and medulla. And train those systems we use to actually do movements and everything. So train the vision system, train the vestibular system, and the movement and sensory system, so they work together with small drills, and then actually can change the whole feel-good feelings in your body. And if you work with the laser in these different levels of the vagus nerve, the brainstem, the organ, the insular cortex, so can you actually change the whole parasympathetic feeling in this body and in this person. And over time, yeah, as Dr. Trevor and Jake said, you can actually change the medication, and because you're working with their own system in the body. So I like to think it as a bigger picture, so you can start doing a lot of cool stuff with how the brain works and take care of you. So if you know your brain and the interoceptive system, you can do a lot of cool stuff, both with drills and the laser. Thanks.
Sanna, that was a great reply. Thank you very much for that. Very detailed. I think all the replies were. So I think hopefully Sarah will be very happy with the answers that we've got for her with that one. Right, the next one, I'm going to move on to Dr. Rishi Loti, who's a chiropractor at the Spine and Joint Centre in London. We've been dealing with Rishi quite a bit recently, so I will bring up his question for you all.
A quick question. Could we use the laser for concussion injuries? If we could, which laser would be best and what would be the protocol for using it? Thank you.
Great, Trevor?
But that's going to be basically a three-part answer, because the first thing that really needs to be stated is that, yes, unequivocally, you will want to use laser to pre-treat the brain on every patient that walks in your door. And what I mean by that is that if you pre-treat with transcranial low-level laser therapy with the Erchonia products, you will have far superior outcomes in traumatic brain injury. Everything from leaky gut and leaky brain, or disruption from the blood-brain barrier from the TBI, that acute inflammatory cascade, the perifocal spreading that happens. So like when a nerve gets damaged or injured, it can explode, if you will, with that apoptosis, and that creates a spreading effect, and it starts wiping out adjacent neurons. So studies show that if you pre-treat the brain and then you have a head injury, the effects of that will be much better for those outcomes. The next phase of it that we go into is in the acute phase, because all TBI should be self-limiting within about a 3-week span, no matter what you do. But what happens is you have this acute massive glutamate excitation that happens, and that opens up the channels of the neurons that causes excess sodium and calcium influx. And again, that can lead to apoptosis and neurofibrillary tangles, or those protein misfolds. So the first thing we do in acute phase TBI is we like to slow the brain down, as far as you want to get that laser energy in there, but you don't want to have like too much excitation of the system in that initial first 2 to 3 weeks. So what we'll use is a 1 hertz frequency, which is very good. It's got that nice slow delta, but 1 hertz is also very good at interhemispheric communication and things like that. The other one that you want to use in that acute phase setting is going to be 10 hertz, because the vagus system, as Sanna just so eloquently described, is so important in this setting. Basically, we're seeing everyone that has a concussion, a traumatic brain injury, develops leaky gut. And studies show that if you do vagal nerve stimulation within the first 6 hours of a TBI, you can actually mitigate the leaky barrier system and the barrier system disruption. And so there are multiple papers, there's about 6 or 7 ones I can reference, showing that the vagus nerve loves the 10 hertz frequency. So in my first acute 3-week phase, I will do transcranial and vagal stimulation with a 1-10-1-10 setting for the handhelds. Or if you have the FX, you can obviously scan it between those on the diodes. With my FX, I will do frontal and vagal stim at the same time. With my handhelds, obviously, you can do some brain-based stim and some vagal stim. So I can get the notes for my exact, how long we do it for. And I'll do that about 3 times a week for the initial acute phase TBI. And then we look at, and then I'll also laser the gut as well too, just to help with that brain-gut axis. And we'll expand on that as the day goes on. But that vagus system that Sanna was talking about, there's over 5 times as much information that comes up the vagus nerve from the gut to the brainstem as there is efferent outgoing information. So you want to laser the vagus nerve right here as the main point, right where it runs along the SCM, and then you want to laser the gut as well. Then you start getting into more active care and more chronic post-concussive syndromes, if you will. If you have symptoms beyond 3 months, then you're dealing with those post-concussive syndromes. And the biggest culprit that we see with that are those microglial cells. So those little supporting cells in the brain, those when you get bam, hit in the head, those glial cells that you guys will hear me teach, they turn from the Bruce Banner super sharp scientist into the Incredible Hulk. And the Hulk is there to protect you. It's called that M1 phase of gliosis. And we need that initially, but what can happen in chronic TBI, either they get bam, hit again too soon, or they have systemic problems, like they have viruses that they're dealing with, or they have other causes of systemic inflammation, like food intolerances, and the list goes on and on. That Hulk will stay primed. Well, one of the best device on the market, on the planet, that everything I've seen clinically and with research to turn the Hulk off to back into the Bruce Banner is red laser to the brain. So it's the most important thing in this setting is to have red laser. I love the EVRL. We'll keep expanding on that as time goes on. But those are your main big 3 components with laser integration. And then I can get more into other things that happen in chronic concussion, like sensory mismatch and HP axis stuff that we'll use lasers, like when the brain's shutting down, or with direct diffuse axonal injury, you may get decreased pituitary output to the adrenal glands, to the testes or ovaries. to the thyroid gland. So one of the other big issues with chronic concussive symptoms is that HP axis has to be upregulated or modulated to get that working better. So we'll even use lasers in that setting as well, directly on the testes, on the thyroid gland, things like that. So those are just some tidbits, but as we get more active, we'll start to increase the frequency settings of the laser. You guys will hear me talk about my base brain setting. I'll just mention it right now. I use 1, 10, 40, and 60, and I'll keep I'm going to hand the mic over to the rest of the panel right now, but I'll expand on why we use that later.
Great, thanks, Trevor. Jake?
Fantastic. Yes, so I always think with TBI, because of the processes that Trevor just described, you haven't got the energy to do all the normal processes you would do in your normal life. So if you think of the symptoms of TBI, people are going to complain of brain fog, dizziness, fatigue, and headaches. A lot of that is coming because the brain is using huge amounts of energy to clear up the debris and rebuild connections and rebuild new neurons. It's a little bit like if you came home and there's been a burst pipe in your house. You've got to pull down all the plaster, you've got to clean up all the water off the floor, pull up the floorboards, and then you've got to rebuild it. And all that takes time and energy. That plays a problem for your traditional treatment as a physical therapist, because the patient can only tolerate so much input. So you can run in that acute phase or even the subacute phase, and with the best intentions think, right, I'm going to mobilize, I'm going to do gaze stabilization and saccades and vestibular rehab and all the stuff. But if the patient doesn't have the energy to tolerate any of that, you can make them worse. And I'll put my hand up and say I've done it, and I imagine most of us have pushed patients too hard at some point. And yeah, and then you think you've done a great session, and they cancel the next one because they're like, man, you gave me a headache for 2 weeks. I couldn't leave the house. So where I personally have found concussion and laser has been my favorite application for the laser, because it has drastically reduced that for me. You can come in, hit them with a laser before you've done anything, and they just tolerate the results much better. So when you're doing your rehab, you want to be always looking at your autonomic signs. So you're looking for signs that, changes in pupil dilation, heart rate, blood pressure, all that basic stuff. And I just find with the laser, they tolerate it a lot better. The big one for me was I used to get stuck on fatigue. So patients would be, their dysmetria and problems with balance, coordination, posture would go, and they would still be telling me, yeah, I can do all that stuff, but I still can't sit in a restaurant and have drinks with my friends for an hour. I still can't go on the tube because that stimulation is too much and I'm just wiped. And the laser for me, using it in the way that Trevor described, has drastically changed that fatigue aspect goes. And I think it's just because it's giving the brain that's just sucking up energy and expending huge amounts, it's just passing them more energy and saying, hey buddy, I can help you out with that. So in terms of the actual application, I'm not going to add anything that Trevor has, but in terms of the confidence it gives you, for me, it's been huge. I'll pass on to Rob.
I suppose for me, it's a little bit different, because until I spent time with Trevor, heads were something that sat on top of shoulders, and I preferred to leave them there because they weren't something that I wanted to meddle with too much. But having spent some time working with Trevor, I came back with his frequencies that he's going to talk about, so I'm not. But the one thing that I always learned from Trevor was the first thing in anything, whether it's a brain injury, whether it's a concussion, whether it's a strain, whether it's whatever, life, the first thing basically is prehab. We should prehab everything. We should prehab every day. We should use the lasers to protect and prehab ourselves, as Sanna would say. And I think once we do that, I kind of take a simple approach, a simple look at these things in terms of brain injury, in terms of concussion. And the first thing I think of is we need to slow down. So Trevor said slow down. So yep, we need to slow down. The next thing we need to do, Jake alluded to there, and that's clean up the mess. Give the body the energy to clean up the mess. And then the third thing that I like to do is give the energy to help sort that out, because the body has gone into deficit, the brain has gone into deficit, and because of this deficit, it can't always function the way that it needs to. So we hold in our hands, whether it's one of these or whether it's an FX, we hold something that is very good at that electromagnetic energy transfer. So all we basically have to do is get it on there. Where are we going to put it? I tend to do a lot with the vagus nerve. I tend to do a lot, as Trevor said, with the various positions of the brain. Do I exactly understand what I'm doing? No, because I'm not a chiropractor. I'm relying on the knowledge from you guys. But I think once you have these devices, once you slow down, once you instigate that cleanup process, and once you get the energy in there, the body is quite good at knowing what it's supposed to do. It just needs us sometimes to give that energy. So, Sanna.
Sanna, yes, that's me. So, I totally agree with the panel here. It's a lot of stuff going on after a concussion. If they're on new concussion or an old concussion, doesn't matter. And you can always retrain the system. So I just want to add to this that it's really important to resetting the midbrain. And you have cranial nerve 2, 3, and 4. That's your vision system, because a lot of stuff going on after concussion in your midbrain. So you can work with the laser. Jerome has some specific frequencies in his book, just to the eyes and the different nerves in the eyes. You can work with them, except the frequencies they already have talked about. So you can work with the eyes. So you can do drills for the eyes, while you treat with the laser. It's really effective because you can really spot on the different cranial nerves and at the same time actually laser the brainstem. A tip for you is try to use some colored glasses, and that will actually make you have some information about if you need to up or down regulate the brain. So you can play around with colors to see which kind of frequencies you actually can use when you treat the concussion. It's just a tip from me.
Yeah, some great answers there. Thank you guys for that. I will move on to the next question, which is from Martin Anderson. And Martin always gives very charismatic videos, if you remember from before, which we all enjoy. Not that I'm building you up too much here, Martin. He's a chiropractor from Morley Chiropractic Clinic, and he is an EVRL owner. So let's see what Martin has to say.
Good afternoon, and thank you to all the members of the Brainwave Trust.
Simon, you may want to replay that video because we can't hear anything. I don't know if anyone else can hear.
I lost the audio as well.
Yeah, we can see the video, but we can't hear the audio.
Sorry, guys, I muted myself, which I think had an effect on it, so I'll start it again.
Good afternoon, and thank you to all the members of the Brainwave Trust.
Yes.
As ever, I'm very appreciative of your input, and I've thoroughly enjoyed all these webinars over the last few months. I had an interesting question. How might we use the laser to its best ability to engage in patients in a prevention rather than cure prospect? So quite often I'm working towards prehabilitation with patients rather than rehabilitation. How can we optimize patients' biological function using the laser and other modalities so they can operate at the highest possible level? And I was wondering if you might have some ideas. It's a bit of a strange question, I know, but it just suddenly occurred to me that how do we make a good person feel better rather than cure a bad person? I'd certainly value your input. Thank you again for giving up your time to educate the rest of us, and I'm looking forward to any pearls of wisdom. Keep well, keep healthy.
Yeah, that's something that's coming up more and more now, and you guys discussed it to a certain level on the last question regarding prehab. So over to you, Trevor.
Yeah, I don't think that's a weird question at all. I think that's a brilliant question. I think it's one of the most underutilized and underserved areas is optimization. We get a lot of Olympic athletes here, or a lot of CEOs of Fortune 500 companies and whatnot that just want that edge. They want to maybe shave off 1/10 of a second of their reaction time or something to that effect. So when you think of it in that context, one of the best ways to increase brain activity and efficiency is energy. And Rob already mentioned, he did a great job talking about getting that energy into the system for optimization. In particular, some of the areas that we want to look at are the newer parts of the brain. And I know Jake can speak to this better than anyone. When you look at areas of higher motor and executive function and cognition, you're looking at areas like the dorsolateral prefrontal cortex and the lateral cerebellum, and you can do animals with it as well too. So, Rob, were you doing a treatment on your cat, Rob? But you can do those different areas like lateral cerebellar output and prefrontal output. So I will bias my lasers to those regions of the brain, prefrontal regions of cerebellar activation, and then you always want to stack your therapies. You always want to co-activate while you're lasering those critical parts of the brain. If I'm working with an Olympic athlete, I may have them doing a certain motor pattern while I'm lasering their cerebellum or frontal lobe. Or if I'm an executive and I may have them doing some stuff like speed reading, for example, or whatever they're trying to do that they want to optimize, and laser their brains while they do that. So yes, I think that's a very underserved and a full market to tap into, is getting optimization of function.
Yeah, so for my patients, and I think this is a very chiropractic, that's a very holistic thing for chiropractors to do, right? Someone comes in with low back pain, you don't just go straight to their low back, you're going to look at the rest of their history and the rest of their physical exam. And so I've just extended it from there. So thorough history, and you're really looking for what are your strengths, what are your weaknesses. If they mention something like, you say, are you clumsy? Are you dropping things? Are you tripping over your feet? Is your partner always annoyed you're smashing glasses? If they say, yes, I've always been a bit clumsy, rather than just laughing about it and brushing it off, you want to go and examine the cerebellum and look at dysmetria and dysdiagotokinesia and all that kind of stuff. And even if they're only, let's say they are coming with low back pain, you would still want to go and treat the cerebellum and those active areas that they've identified in their history. So thorough history, thorough exam are the keys for prehab. So I had a patient referred in by chiropractor just the other day. She has a mild resting tremor. She has no other signs of Parkinson's. She has no other cardinal prodromal signs. So the prodromal signs for Parkinson's can be 5, 10, 20, 30 years before the cardinal signs. So that would be anosmia, so you lost a sense of smell, depression, and constipation. So she has none of that. So I'm not worried that she's going down a Parkinson route, but she still has that resting tremor, and she had a mother with Alzheimer's. So that's a case where I'd say, right, I'm not worried about you now, but you do have a history that's not, we have a family history there, and we do have that little resting tremor. So let's just start changing lifestyle. We'll start putting in intermittent fasting and all those good things, and we'll just use the laser on the areas of the brain like the basal ganglia, the cerebellum, that might be associated with that resting tremor. Two things for me that are part of the examination that key are gait and balance tests. One of the things I work with most in my clinic is falls, so risk of falls. 30% of people over the age of 60 fall each year. Half of all 80-year-olds fall each year. It is one of the leading causes of pain and disability in our society, and one of the leading causes of death. So if you're over the age of 60 and you're hospitalized, there's a 50% chance it was related to a fall. So for me, that is where a lot of my prehab goes. Someone comes in with back pain and I see they've got a slightly wide-based gait. They can only stand on one leg for a few seconds without putting the foot down. They laugh about it as if, oh, I've just had too many drinks. But for me, that's a sign of you're not doing well. Let's start prehabbing that so you're not going to be in that 30% who are going to fall this year. I think we all, I hate to say I've just, I lost my grandmother to this, and it sounds like we're about to lose a grandfather to this. That's how we go. We fall and we hit our head. So the more we can use the laser to prevent those falls, the better longevity, the more we can enjoy life.
I think, how do we make a good person feel better is probably an excellent question. But I think it's probably the easiest thing we can do with our lasers, and it's probably the thing that we most or we least do. I think at some stage in our lives, we're all going to have something that goes wrong. And all we can do is mitigate against that so that when it does goes wrong, it goes wrong in a lesser way or whatever. And I think what I've started doing in our clinics is we are now running programs for basically wellness programs. And what we basically do is we get people in, we give them an assessment. We will check their gait, check their balance, the way Jake has said there. But as well as that, we will get them to read nursery rhymes. We'll get them to tell us stories, and we'll listen, we'll look, we'll smell, we'll see what's going on. And we basically put them into what I would call a prehab wellness program. And all that basically entails is I'm in the Republic of Ireland. My patients, for some reason, pretty much crap themselves if I say I'm going to stick a laser on your head because they've watched too much Star Trek or whatever. So what I basically do is I get them to sit on a couch and we put the FX laser on them. And we put one head pretty much in the middle of the C-spine, one head at the mid-base of the T, and one head at the base of the LS spine. And what you're basically doing there is you're pretty much covering every single nerve that exits the brain. So you're treating the brain. And we call it a conditioning, and it makes people who are feeling good feel even better. You ask them, how does it make you feel? What has it done? They can't exactly tell you what it did, but they just say, it makes me feel that much more sharp, like Trevor said in the beginning. So I think don't underestimate what you've got in your hand. As I say in a lot of the lectures that I do, Madawa's hypothesis basically says that the minute we have that first reproductive cycle in our lives and we have kids and all of that, basically our body goes into decline because we're designed for that one moment in time where we procreate. After that, our cell energy begins to fall off. You have a device in your hand that puts that cell energy back. Maybe you're still going to die at the same age, but you can do it in a lot more style and with a lot more panache than you can with a laser. Sanna, your turn.
So I like this prehab thinking. I do this every day with my clients. I'm a really prehab girl, and the brain is predictive in nature. So we need to see the pattern that the brain uses every day to handle you in the environment you're in. So we have those three systems. You have proprioception, you have exteroception, and interoception. If your brain can't handle the signals coming in your input signals, it interpreted wrong, that's actually becoming a threat to your survival. And that's the pattern of the brain, and actually create a bad output. So if we can train those systems to increase the quality of those signals, the brain can better interpret you, make better decisions, and create a better output. And that actually optimizes your brain. So think that you can actually use the laser as the panel have talked about, and in every one of these input signals, actually laser it meanwhile you're doing the drills that actually will explode your brain. That will be amazing to do with every people, every client, yourself, your family, and the whole world. That will really, really change a lot. So there's a lot of stuff you can do in prehab thinking. Thanks.
Thanks for that, Sanna. We'll move on to the next one, which is Julia Waring. Julia's left a few videos for us on previous webinars as well. She has her clinic in Lichfield, and she owns the PL Touch laser, which is red light, compared to the EVRL, which is violet and red. So here is Julia.
Hello, my name is Julia Waring. Do you have separate protocols depending on the neurological problem within the brain, such as Parkinson's or
Sorry, guys, I think Julia seems to be buffering here. Give it a little bit longer just to see if it comes back on.
Dementia,
Here it is.
etc. Or do you use the same protocol with all these neurological degenerative diseases? Also, which frequencies do you decide to use? Do different tissues prefer specific frequencies, or is it a matter of, in brackets, luck, or seeing what works best? Thank you.
That's great. Thanks for that, Julia. Julia, I think we managed to get the gist of that. Did you guys get it okay, Trevor?
Yeah, so just to kind of paraphrase, she was asking about, do you have different protocols and different frequencies for different neurodegenerative conditions like Parkinson's, like Alzheimer's, like dementia and whatnot? So the short answer is yes. Unfortunately, I can't get through that topic in a 15-hour seminar that I teach, let alone in 15 seconds here, but I'll do my best to kind of give some clinical nuggets on that front. So the main things you want to look at with regards to Parkinson's is that that's a condition that tends to perseverate on a beta hertz oscillation. And beta hertz is at 13 to 30 range. So we typically will avoid that frequency band with our Parkinson's patients. Now, just to branch out from the Parkinson's front, studies have shown that if you put in vestibular activation at EVS stuff of 4 to 8 hertz and 50 to 150 hertz, that is very good for Parkinson's condition. So one of our three main settings that we use for Parkinson's, one is to do mastoid laser of 4 to 8 hertz and 50 to 150. We like to do that a lot of times in combination with quick eye movements like saccades, because that your substantia nigra, where those Lewy bodies infiltrate from the vagus nerve, from the leaky gut, and everything that we're seeing that Parkinson's stems from. As those protein misfolds plant themselves in the substantia nigra pars compacta, one of the areas that's involved with that is fast eye movements or saccades. So we'll do quick eye movements, for example, while we're lasering the mastoid. Another big one you want to do with Parkinson's, because of that whole brain-gut axis associated, it comes back around to vagal nerve stimulation. So we'll do that. But we also know that vagal nerve stimulation in Parkinson's promotes locomotion. So what we'll use is, say they're freezing, for example, when they're walking or doing like get up and go, time to get up and goes and whatnot, we'll do vagal nerve with that, especially with that 10 hertz frequency, while they're unfreezing, if you will, or while they're doing motor activity. Lastly, we know that, say they're having, that right-sided 3 to 5 hertz pill rolling tremor, we know that's, mostly involved with left cortical, left basal ganglionic activity and contralateral cerebellar integration. So you will see me use either my FX or my PL touch in a crossed cerebellar frontal activation with my base brain setting, while maybe they're doing like linear extension work or other types of motor patterning to activate those dopamine systems. So those are our three main areas, target areas with Parkinson's. With dementia, I'll usually do just more of a frontal hippocampal midline, or if we're doing more memory recall stuff, you may see me do bitemporal stuff as well too, for memory recall and things like that. Dementia and acetylcholine and whatnot, for memory recall, that neurotransmitter for memory, that area of the brain, the hippocampus, loves 40 hertz frequency. You'll see it with binaural studies, you'll see it with visually evoked potential studies, different things like that. 40 hertz is really critical for dementia. Now, just the general laser energy, as Rob alluded to multiple times, is just get that energy into the brain, because that's going to be neuroprotective against amyloid plaquing, against neurofibrillary tangles, against brain inflammation and apoptosis. Basically everything that typically wipes the brain out, lasers will not only prevent and protect against that. Studies have shown you can even reverse amyloid. You can reverse tau hyperphosphorylation, or those tangles that gunk up the inside of the neuron and whatnot. So just getting that especially with the red laser on that, that's your most critical thing. So yes, we use different protocols, but those are the most common ones. You're going to see, obviously, with the dementia, I use that 1, 10, 40, 60. For the short-term memory recall and the hippocampus long-term potentiation stuff, it also uses what's called a sharp wave ripple. So you may also see me use a 250 hertz frequency, just for like quick memory burst stuff for short-term recall and things like that. So, but my main two are going to be those Parkinson's ones, and then the Alzheimer's with 1, 10, 40, 60. But I could, unfortunately, this is a topic I could, talk for 6 hours on just on this, but I'm going to hand it over to Jake and give some time there.
That was fantastic. Could I ask you a question, Trevor?
Yes, sir.
So when you're doing your saccades, what's the frequency of the saccades that you're doing? Are you going for like, let's not get too complicated. Are you trying to do one and then a fixation and then one and a fixation, or are you trying to get patients to do it pretty rapidly, or are you doing one hold?
Well, you brought up the great point earlier, Jake, about fatigue ratios and monitoring what the brain can tolerate. So all of my applications on that front are really dictated by, because you get patients that they're some of the most neurodegenerative patients out there, and they can't tolerate, maybe a focus builder app or something like that, it's hammering a gap saccade in that quick of a fashion. So, or we may be using that for those gaze holding centers for that balance that you're talking about. So we may do a saccade to a target and then go into a no gaze stabilization, saccade to a target, no gaze stabilization. So that's really dictated by the patient's fatigue ratios, like you were talking about monitoring autonomics, pupil fatigue ratios, pupil dilation and all that stuff.
Yeah, fantastic. I probably haven't got a lot to add, really. With some of these degenerative ones, I go back to basics. So I tend to think the primary goal of the brain is movement, and so the brain needs to, you've got that feedback loop. So receiving sensation, processing that sensation to then produce movement, and that movement doesn't have to be musculoskeletal. It can be autonomic. It can be dilation of a pupil, the ability to speak and swallow. If you think of your Parkinson plus syndromes, where people might not be able to move their eyes at all, might not be able to swallow to get that horrible dysarthria, dysphagia, things like that. So I'll often do vibration, percussion while we're lasering those basal ganglia areas, cerebellum, and things that Trevor has already talked about. So certainly as a chiropractor, I might just do a lot of my your basic chiropractic stuff, driving sensation, and then encouraging the patient to produce movement off that, and just using the laser to give them the energy to produce it. I love with those kind of ones with Parkinson's, that autonomics, you often see they have those just horribly dark purple fingers and toes. You can do your finger tapping to see can they do 10 in a row, or are they freezing, are they hesitating? And you've got that finger tapping, that Parkinson rating scale that we won't go through now, but it's good to go and study. Another way to check whether you're overlooking them is just looking at facial expression. So with Parkinson's, we often have that masked face where they just lose all facial tone and they don't laugh at your jokes even though you're hilarious. So if you see during the thing you're having conversation, you're being witty, and you get a little spontaneous smile, fantastic, you keep going. And if you see the opposite, they get more glum and less impressed with you as you go on, take that into account. Be aware of the whole and not just focusing on one thing, but check all the, take it all in. Great. Over to you, Rob.
I think you guys are the experts on this. I'm not. Do we do stuff with Alzheimer's? Yeah. I tend to use pretty much the guidelines that Trevor said there, which is I use 13, 16, 24, 30 for Alzheimer's patients. And we basically, I don't have the knowledge that you guys have, so I kind of look at it as a little bit more simply. Okay, from a medical point of view, I appreciate the condition. I know the development and etiology of it. But my main goal with a lot of these Alzheimer's patients that we would see is they forget things frequently, very easily. So I always work with photographs and pictures, and I get I get basically a son, a daughter, or a relative to basically expose them to photographs that they should know from their past. And we would do that for a couple of days before they arrived. Then when they arrived, we would show them the photographs. We would use the laser, and we would evoke a response. In terms of frequencies for everything, I literally have hundreds and hundreds and hundreds of frequencies. I could talk to you about frequencies all day. How many of those frequencies do I use? I probably use about six sets of frequencies on a regular basis. And if I'm drawing blanks on not getting the responses that I want, then I'm going to get more specific with frequencies to particular areas and particular things. But as a general rule, I have six frequencies. I stick to them. If it doesn't work, then basically we go looking. Other than that, don't change it. You guys know more about this than I do, so I'm going to give you to Sanna.
And I have nothing more to add about the frequencies. They covered it all very well. So, but I like this question in the end, and not because of, she was asking about different tissues and different frequencies, and not because of that question, because of the last word she said that, or is it just good luck to actually hit the spot? And that's actually, I can hear, I want to know more. I want to know more how to use the laser and so on. So I actually got cut on that one. So I think that it's so much you can do with the laser that's not involving chasing pain, point and shoot. Don't take me wrong, the laser are amazing to just point and shoot. They are made for it. But you can do so much more with the laser that we have been talking about, prehab and the brain stuff and everything. So when I treat my clients or when I educate my students, I like to think about 8 levels of how you can use the laser. So I think I just go through them. Maybe that was not her question, but maybe someone else can need it. So I always start with, in the 8 levels, point and shoot, area of involvement, where is the pain? And then we go to the dermatome, the peripheral nervous system. Then you go to the central nervous system in the spine, nerve root. Then you go to the cerebellum that we talked about before, and then you go to the frontal lobe. So you have the recruiting pattern of the movement. And then you can go to the brainstem and cranial nerves. Work with cranial nerves, different cranial nerve drills while you treat with a laser, and you can actually be really specific of what the problem is. And then you can work with the insular cortex through the nose or through the temporal lobes. And then you go to the different lobes. So if we can increase the quality of incoming signals through the lobes, we can make a really big change and optimize the whole brainstem and the whole brain. So of course you co-activate and stack it with drills meanwhile you're doing this, but you don't have to do this in specific order. You can start wherever you want in these levels because everything will change the pain feeling the clients have or the problems the clients have. So just play around with different ways you can actually do the laser and not only point and shoot it names. So play around with it, different levels of how you can treat with pain.
Thanks, Sanna. Yeah, it's a good point. I mean, with the non-thermal true lasers, there's no pain, there's no side effects, no adverse reactions, and I suppose they're there to be played with. We can do our best to guide you through the likes of Sanna, Jake, Trevor, Rob, etc. But yeah, I think each and every one of them probably when they first got their laser had to play around with it themselves, and and tried it on different situations to see what sort of responses they got. So thank you for that.
Simon, before you move on there, Julia just put up another part to that question there, which is interesting. Trevor probably might like to answer it. It's a case of what is the best method to stimulate the mesencephalon or midbrain? That's just basically something that Julia added in there while we were speaking. So Trevor, do you have anything to add for that?
Okay, and I think you guys, I love that, when we start talking about treating the body more globally, swimming upstream, Sanna did a great job. Like even if you got a left toe pain, I always swim upstream to the central nervous system. As we work rostral up into the brain, you can start to isolate. If I need more lower brainstem, like Sanna mentioned earlier, more in that pontomedullary area, I'm going to do more vagal stimulation. I'm going to laser the base of the skull right here, or I'm going to laser maybe in the throat, and then maybe co-activate, have them say ah, 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 or hum and do tongue movements. And you all have my patients like hum the Jeopardy theme while they're counting their teeth with their tongue, or it sounds weird until you understand the neurology of activating the system like that. If I need more mesencephalic activation, that's where I'm going to crank up that's more of your dopamine, your go systems, your get up and go, that kind of stuff. When I'm doing more midbrain stuff, elevating blood pressure, mesencephalic reticular activating system for waking the patient up, and a lot of times with that, I'm coming in nasally. I'm coming up the nose with my lasers on that one, and I'm doing prefrontal activation as well too. So the frontal system integrates with everything, but it's so you can kind of isolate those different areas by, just even anatomically going up with your laser on that setting. And then the frequencies, I'm doing more lower stuff with the vagal, the 10 hertz, like I said, it loves the 1 hertz, things like that. The midbrain, I'm doing higher stuff like gamma wave activity, more of like your 60 hertz stuff, your 40 hertz, things like that, where I'm going to bring that up.
Yeah, that's great. On top of that, you also want to think what sensory and motor pathways are going through there. So you got your lights. So you might not be shining laser straight into the eyes, but you can shine other light sources into the eyes, and different color lights depending on what you're trying to do. And then we got your old eye movements, right? So you can use you've got cranial node 3 and 4 right at the mesencephalon. So you want to be doing different eye movements. Just going back to something that Rob was saying earlier, he was talking about using pictures for these dementia patients. A powerful one is smell. So the olfactory system is the only system that bypasses the thalamus. So the thalamus is like your gatekeeper for all sensation. So it doesn't matter what you're doing, the thalamus has the ability to shut that system out. And if it's not healthy, we're in real trouble as therapists, right? Because if the thalamus isn't healthy, you can put any sensation you want in through it, and it might not let it through. And that's the gatekeeper. So smell is the only one that bypasses that. So you can take smells from someone's childhood, like an old perfume, or I don't know if they're a farmer and the smell of cut grass or wheat or whatever it was, and you can basically give them a whiff of it, and it can be quite emotional. You got someone who's fairly out of it, you get them a smell, the frontal cortex lights up, and suddenly you get this little window. You can do rehab. By that point they're probably not so strong, so you don't want to do much rehab, but you've got maybe a few minutes to do something and then let them settle again. Great, that's my part. On to you, Rob.
You there, Rob?
I'm here, sorry, yeah.
Have you got anything to add to that, Rob?
No, I mean, I think basically it's well covered. I mean, Sanna's approach there was again the same as Trevor's, up the nose pretty much. So, I think that's covered. Sorry for the interruption. Let's go on with the next one.
Okay, no problem. Yeah, Sanna, unless you've got anything to add, I'll move on to the next question.
No, nothing to add. Thanks.
Okay, we're going to go now on. I'll probably pronounce this wrong, so apologies, Linda, if I do. Linda Ornflo. She is from Vital Laser Clinic in Stockholm, and she is an EVRL customer. So I will pull up Linda's video.
Hi, my name is Linda, and I'm a laser practitioner from Stockholm, Sweden, and I use the EVRL by Erchonia. For me, it's essential to help people with head trauma and issues of mental illness. So my two questions are about concussion and brain waves. My first question is, what are the protocols for treating concussion, and are there different protocols in treating immediately after an injury or an old concussion? If you please will explain. And my second question is, what are your experiences?
I'll tell you what, I'll pause that for the time being, and we'll go back to that second question, guys. I think we've covered a lot of this with previous questions, but if you've got anything else to add.
No, I think we did cover that with that first one, pre-treat, acute phase, and then chronic stuff. So I think that was pretty well covered by the team on that front.
Okay, thanks, Trevor. I'll carry on playing the video then. Oh, sorry, Sanna, were you going to mention something?
No.
It must have been an echo. Apologies about that.
Of adjusting different brain waves to create neurotransmitters to support clients with mental fatigue, self-harming behavior, and suicidal behavior. Thank you for your support and your good work in this field. Love from Sweden. Bye.
Thanks very much for that, Linda. Did you catch the last part of that, Trevor?
Yeah, I think so. She was kind of alluding to, really what boils down to, with neurochemistry, your main neurotransmitters are like, you've got your excitatory and inhibitory systems. Like anything in the nervous system, you've always got that gas brake analogy. You have to be able to go But what I dare say is even more important, you got to be able to stop the system. So, you know, for example, with your excitatory glutamate that comes from your Krebs cycle, that gets converted to GABA, which is your inhibitory neurotransmitter. So that is really important, especially in areas like the cerebellum, which coordinates frontal thoughts and things like that. And your prefrontal system is important as well too. So with mental wellness, you really want to focus on the newer parts of the brain, you know, for inhibition stuff, prefrontal system, lateral cerebellum stuff, you know, complex movement stuff, sensory integration that the team's been talking about, things like that. But you also need to look at serotonin-based depression versus dopaminergic-based depression. When they've lost all hope, but they can get up for certain things, like, you know, something they enjoy is going on, or you know, it's a stimulant to them, that's more of a dopamine thing. But when they're away from that stimulus and they're just flat, they've given up hope, they talk about taking their own life or the life of others, things like that. I really look at dopamine systems and that kind of thing. So then you're looking more, again, just like with Parkinson's, in a way, you're looking more rostral mesencephalon basal ganglia, so higher up in the brainstem. That's my target area for that. Versus the serotonin stuff is more in the raphe nuclei, which is more down in the lower brainstem. So you may be doing more vagal stimulation, more deep relaxation stuff, more meditative stuff with them, versus more with dopamine based, it's more go pattern stuff, quick eye movements, targeting movements, motor activity, things like that. Always think brain gut as well. Your gut microbiome is critical for this. A lot of your serotonin for the body is made in that area. So, you know, important gut health, important nutrition. You also need to reverse engineer where the chemical, you know, the neurochemistry is coming from. You know, phenylalanine for dopamine, tryptophan for serotonin, and all the cofactors that are needed for that. You know, your methyl donors, your B vitamins, iron, you know, all these other chemistry things. So it's one thing to have the areas of the brain working well that would actually kind of put, you know, spit out those neurotransmitters, but you also have to have the ingredients for the cake to bake it. And so that's, you also may be looking at more of a chemical profile, you know, looking at some lab markers, a micronutrient panel, things like that as well. And this is an area where we really have to watch medications, because ironically, a lot of these medications that are designed to treat these psychological conditions actually end up being worse for them, because they deplete critical cofactors that are needed for the manufacturing of it. And you may see patients actually get more suicidal or homicidal or things like that on the medication. So medications are not infallible in this, and a lot of times are not, you know, they're not the best form of therapy for those patients. You can even get into right and left brain activity, like people that may not respond well to talk therapies, cognitive, you know, in their psychiatry work, because that's more of a left brain upregulating thing for most people, where your speech areas and whatnot, they just need more meditative type stuff and things of that nature, you know, and just getting rid of a lot of the thoughts and talking and whatnot. So you can even divide up, you know, depending on what kind of patient, more left brain laser stimulation versus more right brain laser stimulation, and the list goes on and on. So I think just as long as people are aware of those different topics, so they know to look under those different stones when they're dealing with serotonin stuff, when they're dealing with more dopaminergic stuff and whatnot. But I'll hand it over to Jake to keep going on that one.
No, that was fantastic. I would like you to just continue talking. I've got nothing better to add on that, so I'll skip my turn. Thank you.
I suppose I don't really have that much to add either, only a little bit from what Trevor said there in terms of ingredients to the cake. I think a lot of the time we can get completely bogged down with using a laser. We can get completely bogged down with chiropractic manipulation. We can get completely caught up in orthotical interventions for patients and stuff like that. And a lot of the time we actually really forget the basic stuff. Good nutrition, good health, good ingredients, good exercise, good lifestyle, all of that. And I think when we're looking at any of these psychological, psychiatric conditions, we need to look at the ingredients that the people are putting in before we jump into a situation where we're going to give an intervention. Because you look at pretty much all of these medications that we get for psychological and psychiatric conditions. And what does it always say on them? May cause suicidal ideation. You know, look at the ingredients of the patient's life. When you've looked at the ingredients of the patient's life, then it's time to basically help piece that back together. Is it time for laser intervention? Maybe not immediately, because they're not in a position where they can receive that. That's my two penneth from a podiatry point of view. Sanna, all yours.
I'd really like to hear Trevor talk more about this, so you can keep on going. I like this subject, but as he also said, and the rest of the panel said, it's a lot of things to take in consideration here, and not only maybe the brain waves. And we are back to interoception and insular cortex. And if we look at the system in the body and look at it from a bigger perspective, you need to see what kind of different areas in the brain actually is responsible for these kind of feelings, and then you're back to interoception. And if you see the center on interoception, insular cortex, the activities that the insular cortex are responsible for is regulate sympathetic and parasympathetic tones, yes, but also bodily self-awareness, sense of body ownership, and feel good. So you need to go back to the whole predetermined pattern of the brain and see what you can do in the whole perspective of everything, and not just chase different brain waves, but they are really, really important to having good function. So you need to start somewhere. Yeah, so go for it, Linda.
Simon, you there?
Gone eating.
Yeah, sorry guys, I think it was breaking up quite a bit for me there, so I wasn't quite sure when it was finished. Can everybody hear me?
Yeah.
No, it's unfortunately the Spanish Wi-Fi signal, but that we've got. But yeah, everybody's finished with that one. Okay, thanks guys. Actually, while we're on that, somebody sent a message through before, when everybody's talking about frequencies and what they treat. Would you change frequencies whether you were treating children against adults, or would it be exactly the same?
I don't necessarily change my frequencies for what I'm targeting, but my treatment times will definitely go down. So if, say, I use, just for a base brain parameter for my FX, say a 10-minute treatment to the brain, for like early teenagers or like 9, 10 years old, I may just do a 5-minute treatment. For pediatrics, I may just do 1-minute treatment. I may even, if I'm worried about a patient's metabolic status or a fatigue ratios or things like that, I may not even start with the brain. I may just do vagal stim first. Or to Rob's point, just getting that laser energy in the body is critical. So I may just start with extremity exposure and then work my way to vagus and then work my way to brain. But very rarely will you see, like, I may change, obviously, frequencies for my autistic patients or things like that based on, more likely to be younger. But that's not it. The diagnosis will typically be consistent with the frequencies. Also, before I hand over to Jake, I'm going to jump back and forth. My patients are starting to roll in here, so I'm going to kind of do like I did last time and jump back on with you guys. So I'll hand it over to Jake. I'll be right back.
Yeah.
Okay, thanks.
I would do exactly the same. So the frequency of treatment might stay the same, but the intensity of that treatment will reduce. And again, just like he alluded, I don't really see anybody under the age of 10. And I'm just very aware that the strength of that stimulus might need to be reduced. So say with if you're doing chiropractic manipulation, we know that the higher up the spine you come, the more proprioception you get. We have more muscle spindles in the upper neck than we do in the low back. So you may not want to adjust someone's upper neck on their first treatment. That's kind of the same approach I would take with all my therapy and with treatment as well. So if I'm doing percussion or complex movements or passive movements, I might start down on the foot or just with the hand, and using laser on those areas as well, or on the lower spine, and then moving way up. I might not on that first session go straight up into the brain or upper cervical spine. How about you, Rob?
I think in terms of the question, it's interesting because I was having a conversation with Jovita this morning about this, and one of the clinics that she uses for referral in Poland. And the question they asked was exactly that, what do we do with kids? I mean, I've treated kids with this as young as 6 months old, and all we basically do is I don't change the frequencies. The frequencies I use are going to be the same for the child as for the adult, because a brain is a brain. Okay, it may be a little bit less developed, but what I'm actually doing is I'm just changing, as Trevor said there, the time interval. So instead of using it for 5-6 minutes, I'm going to use it for 1-2 minutes and stuff like that. Pretty much that's it. I have nothing more to put to that. Sanna.
No, I have nothing to add to that too either. I agree with every one of you.
Great.
Okay, thanks,
Simon.
Sanna. And again, apologies, anybody. Rob, if my signal goes again, if you can't hear from me, if you could take over, please. But for the time being, it appears to be okay. So let's play a video that was sent to us from Victor Kalinin. He's a vascular surgeon who uses the lasers in Russia.
Hello everyone, my name is Victor Kalinin. I'm a vascular surgeon in Russia. And first of all, I'd like to say thank you to organizers for this opportunity to discuss this important topic. And my question is about ideal patient for brain treatment. What patient will respond more efficiently on brain treatment? Which disease will respond more efficiently?
Thanks for that, Victor. And obviously Trevor's still away, Rob, so if you want to lead that. But I think we all pretty much know in the majority of conditions that the way it works is pretty much the same. Would you like to elaborate a little bit more, please?
I think it's a very good question. Who's going to respond more? Who's going to respond less? The easy answer to this is we never know who's going to respond, how they're going to respond, what the response is going to be. What we do know is that everybody we use a laser on will have a response, and that response will be positive. And I think that said, what we need to consider also is our bodies contain everything we need for a happy, healthy life. Every chemical we need, every cell we need, every intervention we need, we contain all of these things. All we have to do is basically activate that. So I'm going to go back to something I said earlier, which is what we really need to do is get the energy in there. In terms of selecting patients, how do we select patients? That's something that's very, very different for everybody. And when I talk to people about lasers and the patient selection, I basically say, look, go out, select your patient, do the medical history, do the lifestyle questionnaire, do what it is that you normally do. And I think Jake will remember this when I was talking to you about it. I said, look, sometimes you'll have a patient that comes in and up here somewhere, somebody is saying to you, don't touch this patient, run, leave them alone. Not your kind of thing to deal with. And that's our gut telling us. So sometimes we have to basically interact with our patient at very much an instinctual level. And, you know, do we choose this patient over that patient? No, but sometimes our gut will say, this is not a patient that I can help. And I tend to go with that. But in terms of the ideal patient for brain treatment, we're all ideal patients for lasers, pretty much all of us anyway. And I think once we get the energy in there, we're not going to really do anything too wrong. But my basic thing with this is we have everything we need in us. All we have to do sometimes is switch it on, let it work, let the body do itself. We have huge potential for fixing ourselves. We have huge potential for healing ourselves. All we're sometimes lacking is the stimulation to do that. I think non-thermal low-level laser through electromagnetic transfer is the way to basically create that stimulation and the way to basically decide and help that intervention. Jake.
Well, because Victor's a vascular surgeon, I'm going to assume that's the majority of his patient load. I've just realised I've not looked at any research in terms of, you know, I've looked at laser and diabetic neuropathy and stuff like that. I've always looked at nerves and brain. I haven't really looked at laser and the vascular system. Is there much research looking at the lasers and their effect on the vascular system, or is it?
there is huge amounts of research on vascular work with lasers, simply because, I mean, if you think of the method of action of this, you know, you've got a laser which is basically getting ATP going, then you're basically seeing things like free nitric oxide, reactive oxygen species, H2O2, you know, all of these vasodilators, constrictors, etc. going on. So I mean, laser in terms of vascular issues, it's very good. I mean, especially when you look at wound healing, you get vascular neuropathic ischemic ulcers, this kind of thing. They're very good at healing that because they're improving the vascular supply to the area. So even when we put these things on the brain, they're improving the blood supply to the brain. And what happens a lot of the time with the brain? Fatigue, brain fog, all of this, what is it? It's buildup of toxins, and it's lack of the body's ability to irrigate that and to take the crap away. So, you know, why does it work so well when we stick it on the head? Basically because we're bringing blood there, we're bringing all of the things that we need there to basically detoxify and carry that crap away. So, you know, loads and loads of research on it. I mean, think of the main action of these lasers. You know, it's increasing blood supply, it's getting lymphatic flow going, it's releasing hormones, it's upregulating, it's basically getting our bodies to produce genes, stem cells, etc., etc., etc. I mean, everything we need is there. So huge amounts of research. Sorry, I'm waffling.
No, that's great. No, that's probably hopefully helpful to Victor. Yeah, in terms of ideal patients, I don't know. Well, I think hopefully through all the different conditions we've been talking about in today's seminar, and hopefully in a few of the other ones, and that you can see the kind of the range of patients that come in. I suppose for me, the non-ideal patients is probably an easier topic to discuss. And for me, it would be the patients who are perhaps too far gone. So the end game, Alzheimer's, Parkinson's disease, dementia, they're so far gone. Their capacity for function is so low that although you might be able to offer them some benefit, it might not be meaningful. And that's kind of when I have patients in, I always ask them, if there's one thing I could do for you, what would it be? That's their goal, and that's what we aim for. Because I'll find something wrong with everyone. So not everyone is interested in prehab, right? Most people have, my back hurts, I want to be better. I have brain fog, I want to be better. So I'll take that goal, and that's what we aim for. But if you've got someone, you know, you've got, let's say, a severe Parkinson's patient, and they've been brought in by a loved one, and they say, we want him to walk and talk and be normal, then that's not an ideal patient for that. So it's goal setting and being realistic with what you're going to achieve for that patient, I think is very important.
Thanks for that, Jake. Sanna, have you had experience in your vast experience of treating these sort of conditions when they're quite far down the line rather than in the embryonic stages of the disease?
Yes, and if you have a client that are really, really sick, I have a lot of those clients in my clinic, and you need to be really careful, but because sometimes it's only for 2 or 3 seconds you can use the laser, and then they actually get a threat response in their body. So the brain is predictive in nature, and it's remember everything you have been through your whole life. So it's really important to know that the history and the treatment needs to be depending on the history of the clients. So depending on what the client wants to achieve, is it an injury or really a sick person, or is it a performance thing? It's really huge difference in treatment and how you handle that person. So as Rob said, everyone is individual, so everyone can react. You don't know how. So it's hard to actually answer that question without a no. Is there more or less person for brain treatment? Everybody needs to treat their brain or optimize their brain, and we have a perfect tool for that. So you just have to, as I say, play around.
Yeah, I agree completely. You know, and this is the thing, I think that the range, and we talk about extending scope of practice a lot with our customers, and the range is so vast. You know, there's so many things you can do, but like anything, it's all a process. You start off with what you feel most comfortable treating, and then as you become more experienced, you know, as per life, you get better and better at it. So thanks a lot for that, guys. Actually, one of the questions that came up there, which I'll jump in with, Sanna, you may have had experience with it. I'm not sure, Rob or Jake, whether you have, but any experience of treating drug abuse? What protocol? More info. Rob Sullivan, do you want to put your four-penneth in?
Yeah, I think this is it's an interesting question because Sanna will remember in Barcelona there, the last time we had a conference in Barcelona, we talked about this, and we talked about, you know, using lasers for addiction, and we also talked about using lasers for memory issues, things where a person would have a fear of something. And we could basically change their approach to that fear with the laser. And I think we played a game, Sanna, if you remember, where you thought of something that you found particularly distressing. We played with the laser, and at the end of that, you weren't so distressed by it. Lasers are excellent in addiction. And what we have to think of too, when it comes to addiction, is the vagus nerve is very important in this, but also what's very important in addiction is the auricular branch of the vagus nerve, which quite often gets forgotten. And I think a lot of the time with addiction, and a lot of the time with I suppose issues with memory or conflict with memory, where basically we remember something that's distressing, the auricular branch of the vagus nerve is very, very, very important in that. I think in terms of addiction, we've messed around with people who've wanted to quit smoking and they've managed to quit smoking, whether it's a case that they've been so scared crapless at the fact that I said, look, if this doesn't work, we're going to stick it on your brain and it fixed them, not sure, but you know, perhaps it was the auricular branch. You guys know more about this than I do. It's just something that when I was working with you, Trevor, I picked up on that, and we ran with it and had a lot of good effects. Just to speak for a second there to one of the points that Jake raised, he's gone for a second, but he's basically saying about if somebody is too far gone for laser. We actually did a research project, Simon, I think you might remember, I still haven't got around to writing it up, where we went into end-of-life care with lasers. And we looked at basically the quality of life at the end of life. And we were able to do a lot of work with that over an 8-month project that we did with the Irish Hospice Foundation a couple of years back. And what we actually found there is, even at that stage, the quality of life can be improved with laser intervention to the extent where drugs aren't always necessary. So anyway, my two-penneth, back to the addictive question. There you go, guys. Who wants to jump in? Trevor.
Anna, have you had a chance yet? Yeah, I mean, Rob, you said it best. The vagal stimulation is huge. Gut microbiome is huge. The auricular branch, so doing the ear-based therapies is spot on. I love that he brought that up. And even the glial system and the reorganization of that. It's part of its job is to make your brain more efficient for stimulus. And that's great if you're learning a new golf swing or something like that, but it's not good when it's adapting to maladaptive behavior or bad habits and things like that. The other big problem with that is your dopaminergic system, your nucleus accumbens, your reward center of the brain, if you will, is very much a dopamine driven system. So we like to do stuff for more like I hate to say it this linearly, but like serotonin kind of competes with dopamine in a way. Like it's not, that's poorly worded, but for the sake of simplicity, let's say it like that. So it comes back to we want to do the lower brainstem activation, like the vagus nerve. That's why those auricular therapy, one of the reasons why those auricular therapies and vagal stim works well in this setting is getting more of that serotonergic output versus that dopamine reward center. I have to have that, I have to need that kind of thing. The other big issue with that is your resetting of your default mode network. You know, that those brain pathways that get ingrained with ego and stuff like that, when you reset default mode network, that's another big one for getting people off opiates. That's why you're seeing all this work from Johns Hopkins, if you will, and Harvard and Stanford and whatnot about using like psilocybin and other classic psychedelics for addiction and opiate withdrawals and things like that. Because when you reset the default mode network, that's how you kind of get a fresh slate, if you will, so you're not as likely to be have that addictive memory, if you will.
Thanks, Trevor. Sanna, anything to add?
No, nothing.
it's like a panel within the panel. I think we're all learning so much of you guys here. One question come in that I think we all know the answer to, but I'll put it to you anyway for those who don't have any experience with non-thermal lasers by electromagnetic energy transfer. If you overtreat with laser, do we see fatigue like overtreating with chiropractic? Trevor?
Yeah, I mean, the reality is that like when we've done the FDA studies on low-level laser, as you've alluded to multiple times, Simon, there has never been a reported side effect. Now, what you will find is as you start bringing the laser into the brain, which I think is the most important thing doctors can do at this juncture, is treat everyone's brains. But you still have to, use that clinical judgment and management, because when the more complex cases you get, whether it's high anxiety cases, late stage Alzheimer's, like stage 6 above, that kind of thing, yes, you've got to use your clinical acumen to potentially dose down on treatment times, because as you start getting that energy and metabolic cascade going and whatnot, if they don't have the right substrate, or maybe they're dealing with an infection in the brain like a virus, hopefully we get a chance to talk about COVID today and things like that, because that's something that is so prevalent worldwide right now. Every single one of the doctors watching should have an EVRL laser, if not for any other reason, just that COVID thing with inflammation and viral activity in the brain. Because that's one of the big things we're seeing with neurodegeneration are these pathogens that are getting up into the brain. So you may have a kill-off, like a Hertzing reaction, or they may be so metabolically unstable that they can't tolerate too much brain-based stuff. But that goes back to my earlier comment about when in doubt, start on the body, start on the vagus system, and then dose maybe a minute or 30 seconds to the brain. Just see how they respond to it. If they do great, then you double it, go to 2 minutes, then 4 minutes, and then you can keep going up and up from there.
Yeah, before Rob answers, I agree. I mean, this is part of the reason why we have specific settings that we put in the laser right from the beginning to give you a guide as to the treatment times. As you become more and more experienced, you start to gauge this yourself. But frequently in a lot of the WhatsApp groups that we've started for our existing customers, they're always asking these sort of questions and how long to treat for, and that's why we put so much focus on training and supporting with this, because we want you guys to get up to speed as quick as you possibly can. So Rob.
Hiya. I do I need to add anything? I actually don't need to add anything.
Good.
Jake.
I'm pleased to hear it. Oh, yeah, Jake's back. Hi, Jake. Sorry.
No, I think the same. I think there's nothing else to add there.
Sanna, any pearls of wisdom?
Always. No, not always, Simon. I would like to go back to the predetermined pattern of the brain, because laser treatment is also an input. Your brain has the brain's first job is survival, and it interprets all the signals coming in and decide what to do with it, and then create an output. And the laser is also an input. So if the brain can't interpret it and decide what to do with the laser treatment and all process that's actually starting in the body and in the brain, that actually becomes a threat. So yes, you can react bad on a laser treatment. It doesn't mean that the laser is wrong. It just means that maybe it's too much or a long time or frequencies and everything, and you need to change maybe the time and where you put it, as Trevor said, start down and go upstreams. So there's a lot of things you can do that doesn't require to take off the treatment. You can still use the laser, but you need to find out how.
I think Simon. I think Sanna just triggered something there. That's a very interesting point. Sometimes the brain will view the laser as a threat. We all have patients that don't respond to laser treatment, and we all look for complicated ways of explaining why the body didn't respond to that laser. And I think Sanna put it there very well. A lot of the time, it doesn't respond because it's a threat. So if it's a threat, what do? We have to change the perception of the brain to the laser. And both Jake and Trevor basically have the solution to that in terms of how do we do that? We start off with a little bit, as Sanna said there, you know, a couple of seconds is all some of her patients can take. I know when we were doing the stuff with the Hospice Foundation, you know, a couple of seconds was all some people could take, but that couple of seconds allows us to build on that and change. So it's never time to give up. It's always time to begin.
Yeah, and you're not waiting for the patient to say, I feel awful. So you're not waiting like, how are you doing? How are you doing? I feel terrible. Okay, I'll stop. Rob, you're really great at this, is getting someone to do like a nursery rhyme, or doing, say, every other month of the year, do multiples of 3, start with 100, subtract 7, to get them to do some kind of task. And if you see them fail at that task, even if it's something fairly simple, like say every other letter of the alphabet, and suddenly they go, you know, A, C, E, that's your first sign that they're maybe getting overloaded.
That's your trigger.
Yeah, absolutely. It might be a twitch of a muscle, right? It might be that there's something their neck tightens up. It might be maybe they do say like, oh, my fingers are tingling, or, you know, something weird, you know, a positive symptom, positive signs, you know, negative sign being that a hand goes numb, a positive sign being that it starts tingling, or they start complaining of pins and needles, ants, stuff like that. So if you wait for them to say, oh God, I feel awful, then you're probably quite a long way too late.
Yeah. Okay, thanks, Jake. Sanna?
No, it's true. I totally agree. You really need to learn to read a threat response on a person, because you need to be looking for these kind of small changes in the face or in the eyes, or as Jake said, it's more twitches in the starter reflex response. So you need to be good to reading that threat response.
Okay, thanks, Sanna. I'll play this question. I know it's a very short one, so I'll put it on. It's from Lena over in Morocco.
Hi everybody, I'm Lena from Morocco. My question is there any protocol for the treatment of Parkinson with LLL? Thank you.
Thanks, Lena. I can't actually see the video screen. Trevor, are you still with us?
So I think we covered that one.
Okay.
I think, Simon, we already covered that. So I think that's already been answered reasonably well.
Okay, let's have a look. There's quite a long one here from Laura across in Belgium. Battle opioids, which I know the US put a lot of focus on, because it's a huge problem across there, as it is with everywhere. The sanitary crisis has been a source of anxiety for many people. Some have been for many years, and the situation didn't help. What would you suggest for recent anxiety, for chronic anxiety and depression? Many medications are prescribed to these people with psychological support for chronic anxiety and depression, or without for recent symptoms. The person is not obliged to consult aside for the prescription, so the consumption of opioids is quite easy with no follow-up. Doctors here tend to prescribe a lot of antidepressants, anything to make the patient better, but chemically, which is the way of hiding the disease and not healing it. Which laser treatments would you recommend for these two groups of people to feel and live better? And again, apologies, I can't see who's still on. So Trevor, if you're on, take the lead. If not, Rob, do you want to get started with that one?
Yeah, I think really in all of these brain-based questions, I always tend to start off with the very basics, and my basics there is what Trevor uses as his basics, because obviously I spent a lot of time listening to Trevor. So I mean, for me, it's basically 110, 110, 110. And then basically, as we've worked through that and we begin to get resolves and responses from the patients, then I'm basically going to change it. I'm going to do 110, 40, 60 as Trevor would do, because of the time I spent with him. So my approach to that would tend to be the same. The other thing we have to bear in mind with all of this is pain is an indication from the body that something is wrong. we always owe it to our patients to investigate that pain. You know, is that pain there because something is wrong, or is that pain there because there's a psychological or a need for that pain? So I think once we've done our due diligences and investigated everything, then we're pretty safe to do that. But I think in terms of what Laura is asking there, the settings that Trevor uses, I think are more than adequate for that. Trevor, you're back.
I'm just reading a question here, so.
So I'll go while Trevor's catching up. So with anxiety, I don't know what Laura does, but from a kind of physical modality point of view, hypermobility and anxiety go hand in hand. So patients with hypermobility have 16 times the rate of anxiety. So if a patient's walking through my door and they have any signs of hypermobility, which you can often see during gait with that hyperpronation of the feet, and you know your basic exam, hypermobility and anxiety go hand in hand. So for that kind of patient, outside of the laser stuff, I'm going to be doing isometric muscle exercises. I'm going to be using percussion in the body, things like that to try and build strength, build a bit more stiffness, just to keep things simple, build a bit more stiffness into the system so they're getting more proprioception when they do move. Chronic anxiety and stress, the natural state of things is if we were still out in the fields during periods of wealth, so plenty of water, food and mates, you want to remember where the food is, where the water is, and who's in your society, who you want to get on with. So what would happen is the hippocampus would swell, become bigger, so basically you'd have more memory. During times of stress, so starvation and threats, the opposite happens. The amygdala becomes bigger and stronger, so that's your threat detection, and it's going to suppress the hippocampus through your stress hormones and through all that other stuff. So what you often see is you have these chronically stressed patients who will often say, I have brain fog, I can't remember anything. And that fear of I can't remember anything is another stressor. So with the laser, I'm going to try and use things to try and, sorry, one part I forgot to mention there is basically, normally it should be the frontal cortex is suppressing that amygdala. So you have a scary thought, you hear a bang, and you think, oh God, it's a gun. And then the frontal cortex says, no, chill out, dude, it's just a door slamming. What can happen is the amygdala gets bigger and bigger and bigger, it can dominate the frontal cortex. So when you hear that bang, instead of going, it was a door, you get, oh my God, there is a gun. And it takes a little bit while for you to get that into control. Meanwhile, your stress response is already shot through the roof and you're getting the heart palpitations and shortness of breath. And because you then feel stressed, you are stressed. You know, it comes back to what Sanna's been talking about. You notice the change in your body and then you think, oh God, why is my body so tense? I must be stressed for a reason. So you want to do laser to the frontal cortex. You want to do therapies that are happy for the frontal cortex and help it basically suppress that amygdala, get the hippocampus to regrow, so you can remember stuff better and feel better. Finally, while I'm enjoying my part in the spotlight, the cerebellum's job is to automate things and make everything effortless and easy, so you don't have to think about it. So when the cerebellum isn't performing well, you can't just stroll through life without any effort. Everything takes more frontal integration, more frontal effort to do the basic stuff. And that's tiring and it's stressful. So again, when the cerebellum shuts down, you have to use your frontal areas more, which is fatiguing, and it makes us stressed and anxious. So the areas I always go for is make sure the frontal cortex is happy, try and calm down the amygdala, try and get the cerebellum to do its job as well as possible, and check for your hypermobility syndromes. They're super, super common. Right, that's me.
That's great, Jake. I'm just going to dovetail off. That was beautifully stated, Jake, because it is really something that you brought up, the isometric thing and the cerebellum and the newer parts of the brain. The main cerebellar integration, prefrontal integration, does really well with eccentric loading of the muscle groups and isometric loading. So you'll see us do like a lot of like glute clamshells and things like that with the big core and proximal muscle. That's why you see studies like squats are so good for the brain and things like that. So we do a lot of, or planks, another good example. You do those midline and core type activation with an isometric, very powerful for those inhibitory systems, those GABAergic systems, if you will. because the outside part, the Purkinje part of the cerebellum, is a GABA-based system. So is like your, stuff with your prefrontal inhibition and whatnot. Then you always got to come back to the chemical level. One of the worst things with anxiety and that glutamate to GABA conversion is there's a molecule called FAAH. Don't worry about the technical stuff with that, but that molecule is inhibited by stress. Stress is obviously a big issue with that. So where do we get the glutamate from? Well, it comes from alpha ketoglutarate, which comes from your Krebs cycle, and that should come from gluconeogenesis. So you always got to go back to a food-based thing with anxiety. Are they eating that? In America, we call it the SAD diet, the standard American diet. It's full of crappy carbohydrates and whatnot. We definitely want to be in a ketogenic or good fat and protein-based bias, even just to get that chemistry right, to have all the molecular makeup for the GABAergic systems, for example. So you always want to look at it chemically, but in the neurology activation side, I know this group does amazing job with doing the muscle activation, and ties into the hypermobility stuff that Jake was talking about, and it ties into all that limbic inhibition stuff that Sanna's been talking about as well.
Cool. Rob, have you got anything
to add?
It's
really great to hear you guys.
No, go on, Sanna.
Yes, actually I have. Yeah. I really enjoy to listen to you because this is such a subject that I'm really interested in. So Jake, you explained it very well, I think. I actually going to give Laura my whole protocol for this, because we are back to interoception, and interoception is here, how you feel, and the center is the insular cortex. So anxiety and depression is a dysfunction in your interoceptive system. So there's a lot of things you can do here, and I'm going to give you actually some kind of stuff you can use. First of all, you need to take a good history. Are there any traumas, mental traumas? And then we're back to what Rob talked about just a while ago, about the treatment he did on me, about the trauma. I had to think about, feel my emotion about it. And he actually took the laser and combed my frontal lobe, as Jake talked about, and did a combing over my whole head and back. Meanwhile, I thought about my feelings. Maybe I have clients that can't think about their feelings because they don't know what to think. So I just ask questions and they talk about it. And when the clients actually feel the emotions is better or the thoughts are easier to think about, the treatment is done. So take a good history, are there any traumas, and treat it. And then you go to, are there any histories from your stomach, and how are the function of your organs? Because in the organs, you have the accuracy of your interoception, how you feel. So you need to look at nutrition, food, bacteria, virus, how well does your organ function. And then you have the vagus nerve. And the vagus nerve also is the primary responsible for your parasympathetic nervous system. So be working with the vagus nerve. And also, as we have talked about the neurotransmitters, you have dopamine and serotonin produced in the stomach, and you have your immune system. So a lot of stuff going on in your stomach. You need to look over the history and the food and how well does everything work in this area. So balance the organ. And that leads us to the brainwave, as I said. Maybe you need to test all the brainwaves. Which brainwaves does this client needs? You go, is it energy or speed? You need to have alpha waves. Is it motivation or desire? You need to have beta waves. Is there happiness? There is delta waves, the serotonin we talked about. Is it perception and consciousness? It's gamma waves. Is it calming? It's theta waves. So there are different brain waves for different moods, and you can actually test these brain waves out. You can test it by asking the client about the history, but also how it feels right now. But you can also muscle testing the different frequencies on the different spots where you actually have the producing of the brain waves. So the alpha waves, you actually have the peripheral lobe. You have dopamine in the stomach, and you have it in the frontal lobe, and substantia nigra is the cephalon, and you have delta waves in the stomach, but also in the occipital lobe, and you have theta waves in the temporal lobe. You can always do the different frequencies of the different brain waves over the stomach because of the interoception part of it. So we go to the vagus nerve. We have heard a lot about the vagus nerve. So treat the vagus nerve. Maybe you need to have different spots on the vagus nerve that actually is more effective than other spots that Trevor talked about. You need to change. If there's a lot of history in the stomach, you maybe not can do the vagus nerve of the stomach. You need to be the upper part of the vagus nerve and so on. Play around with it. Insular cortex, we're back to insular cortex. And as I said before, the insular cortex is responsible for integrate the different systems we have in our body. So small drills that actually integrate movement with vision, with vestibular drills. So this is a really easy one to actually try with your clients. So do some tests. You can do a breath taste. How does you feel right now? Do you have any pain? Or you can do a movement range of motion test. You can do a muscle test, and preferably a midline stability test because of the interoception part. So you just take something that you can target your eyes on, a letter. In this case, you can use actually a letter on a pen. So let the eye target the pen. And just do a small movement with your head. You have movements in your neck, you target with your brain, and the vestibular system needs to be active because you change your head according to the gravity. You just start with one round. I don't know what it is in English, but you know what I mean. Just go one ahead around and each way. And try again, test again. And that small drill maybe take like 5 to 10 seconds, and then can change the feel-good feelings at once, because when you change the activity in the insular cortex, who's responsible for your feel-good feelings, that actually can make you feel good at once. And if you actually can treat with a laser with the different frequencies we are talking about at the same time, you get tremendous results because of how you actually use the pattern of the brain. Then we work with the brainstem. You have different cranial nerves for different things in your body. That's what we have been talking about. So you have 3, 7, and 10 cranial nerves that actually work with the parasympathetic system. Then you have cranial nerves 9, 10, 11, and 12 that works with the medulla, the lower part of the brainstem. They have cranial nerve 10, it's vagus. So what's fired together, wire together. And you can see a lot of people, as Jake talked about, that has they are stuck in the starter reflex or tense reflex in their body. And this reflex is actually cranial nerve 11. So when you work with this reflex, and if you work with cranial 10 or 12, that fire off to each other. So you can change a lot of stuff just playing around with different cranial nerves that are just aside the 10 cranial nerve. So let's fire off together. So you can work with the brainstem through your mouth that we talk about. Don't forget your tongue, because you have 5 cranial nerves innervate your tongue. And if you look at the motor cortex and where the tongue is placed on the motor cortex, it's actually really close to insular cortex. So everything you do with your tongue can actually change activity in the insular cortex. So if you see a client or patient or person, maybe your kid, actually use their tongue when they're writing, or as I see in dancing, a lot of people use their tongue when they're dancing. That's actually that they require more activity in the insular cortex to integrate the whole system, every system we have. So all these drills you do while you treat with a laser, those drills can the clients take home and work with, so the treatment from the laser actually can keep it up. Meanwhile, they don't have the treatment. So if they do it as a prehab, or if they do it in the moment that actually feel anxiety, you actually can change the brain's own pattern to take care of you in these moments that they actually have this depression or anxiety, or feel more bad in their body and in their mood. So don't forget that these incoming signals need to remapping even in this kind of different conditions and diseases. So if you remap and all the time educate your brain to handle you so best they can do, you actually get a really big change that's gonna last a long time, forever, maybe. Yeah, thanks for me.
Yes, Sanna, that was a great explanation there. For all three of you, Rob, I want to move on to COVID-19 situation. Do you have anything short to add before I do?
No, I already started at the beginning, so I've already said my bit on this subject.
Okay, guys, there's a few questions coming in just with regard to what clinics are doing for patients to either, protect them from viruses or what have you. Trevor, what's your experiences been thus far in the US, please?
Yeah, that's, I mean, you talk about a gem of a device for being preventative for COVID potential. Now, I got to be careful, obviously, watch my verbiage here. Obviously, you're not treating a pathogen like SARS-CoV-2. You're helping the body's natural immune systems, its natural physiological responses and whatnot. But when we take on COVID over here, it's basically three main sections that we're looking at. One is prevention. So how do you improve your immune function and whatnot to prevent that S2 spike, if you will, for harpooning that ACE2 receptor in your lung tissue. The next is if you're actively fighting off an infection, how the lasers and nutrition can be used with that. And then lastly, and this I dare say might be one of the most important things, is that we're seeing an influx of the post-COVID exposure. We're seeing all the neurological sequelae or consequences to it. You guys just launched a study. It came out of the UCLH-led study that just came out 2 days ago, talking about the post-COVID findings, and they were showing that of the big things, we're looking at the ADEM prevalence with it. We're looking at the systemic inflammation, and the delirium and some of the other, the stroke increases, all these other things. And this was even in some of the younger demographic, because, everyone's kind of under the impression it's just the elderly, the immunocompromised and whatnot. But if you get exposed to COVID, it's that upstream brain sequelae that we're actually having to deal. Like we're seeing now in a trickle of it come into our office as well too. And so the lasers are perfect on basically every level of the equation. We know that the interleukins that are like the big problem with COVID is this, is that the body gets attacked by this virus, and it's an RNA replication virus. So we inhale it, we get it from aerosolization for hand to mouth stuff, that kind of thing. As it comes into your system, it harpoons your lung cell called the ACE2 cell, your angiotensin cell, and that's your surfactant cell. So then it starts to replicate in there. Well, then it starts to call, so you have what's called your innate immune system. But then it calls in your cytokine responses, your inflammatory messenger storm, if you will. And that inflammatory storm is what it does is that inflammation overshoots the target. So we need that inflammation to come in and fight off the organism. But the problem with COVID is that it overshoots the target. So you have this massive inflammation overshoot. And so you have to be able to mitigate or shut that down. Now, certain things like vitamin D is one of your most predicting factors on your outcomes with COVID, both in your ability to fight it off and your ability to have resolution. But when you have that systemic inflammation, that's what's really going up into the brain, and that overactivity of inflammation, like nuclear factor kappa beta and interleukin 6 and interleukin 1b and all these inflammatory chemicals that go up there, that's one of your mechanisms of loss of smell, for example, or the delirium, those kind of things. And that inflammation cascade can lead to alterations in blood pressure and blood flow and autonomic regulation. The list goes on and on. So we use our lasers, especially this violet. We'll treat the violet-red combo. Will actually take out viruses. It can stop, viral replication. It can help inhibit or just destabilize the capsid of the virus. So you can actually mechanically wipe out viruses with this device, like we've seen in cytomegalovirus studies, things like that. We also know these devices will penetrate the skull. That was another big one that we had to prove early on. I had Steve Shanks do that study with the handhelds on penetrating the skull as well. So we know that that these lasers are good systemically for protecting your lung tissue and actually having an antiviral component. So we'll do treatments up the nose, in the oral pharynx area. We trace it on down the trachea and into the lung tissue. And I just use the base virus setting that's in Jerome's book for that, or the base immune boosting setting is another one that I've been using. But what we're seeing in the post-resolution phase is that there's no better way to shut off inflammation of the brain that I can think of than using the laser on the brain. So that's another big thing with the COVID activity that this device is, it's pre-protective, but it's also a resolution. Those SPMs like omega-3 fatty acids are good with resolvins and protectins as well too. Just some other side nuggets for prevention of COVID or even RNA replication. We know zinc will help prevent RNA replication. We know melatonin will do it, and we know N-acetylcysteine does a really good job with it. As far as early prevention, your innate immune system also really needs a lot of your sulforaphanes or like your broccoli derivatives and vitamin A and vitamin C and vitamin D. So those are big things that everyone wants to be consuming right now, high amounts of as a protective thing. And we also like products like Andrographis, which is a really good antiviral thing as well too. Maybe I won't. I can get you guys. I'll get you guys. I did about a 2.5-hour webinar on just COVID stuff with laser protocols, with nutrition, whatnot. So Simon, what I'll do is I'll send that to you so you can just send it to all the attendees. I'll hand it over to Jake.
Yeah, that's great, Trevor. Thanks for that. Next, Jake.
No, that's fantastic. I've got nothing to, I'm not going to be able to come anywhere close to that. That's fantastic, Trevor. Simon, I'm afraid I've run out of time, so I'm going to have to log off. But thank you to the rest of the panel. It's been really interesting. I've enjoyed speaking to you all.
See you, Jake. I'll talk to you soon, buddy.
Cheers, guys.
Yeah, we're just about done. Thanks very much for your input, Jake.
Bye, Jake.
Bye.
Bye-bye.
Rob, do you want to take next year? I know you wrote an article on this.
Yeah, I mean,
before we move across to Sanna, do you want to take the next
one? COVID was very much my pet right back in November when I wrote that paper, and nobody was really that interested in it. COVID is interesting insofar as the disease, even though it kills you, is not really the thing which I would be most worried about. I would be more worried about what happens after COVID basically dormants, because I mean, as Trevor said there, we have neurological functions, we have endocrine function issues, we have endocrine function issues, we have vascular function, digestive function, renal function, respiratory function, the whole lot. I mean, it basically affects and throws a spanner in the work of everything. I think the interesting thing about COVID in terms of the virus itself is it's wrapped in a lipid bilayer, which makes it quite extraordinary in terms of how it functions, because unlike most coronaviruses that just basically hang around for a little while, this is wrapped in a lipid bilayer, which is basically fat. What do lasers do? Kill fat. They break fat down. They emulsify fat. So just the effect of that itself allows the body's natural responses to work in. How do viruses wrapped in fat really start to work? They work through inflammation. What do our lasers do? They quell inflammation. So the more inflammation we take out of the system, the less likely this virus is to get a stronghold. So we're not talking about using something to cure a virus. We're talking about something to reduce that viral load. And if we can reduce that viral load, then our body can basically work with that. So, when you're dealing with a coronavirus that has a lipid bilayer, this modus is basically, let's create as much inflammation as we can. And then while we're off dealing with that inflammation, now we can infiltrate other systems like neurological system, endocrine system. The only thing that we really need to do is knock out the inflammation, because if we knock out the inflammation, then our body can kick in and do what it's supposed to do. Add, as Trevor said, adequate nutrition to that, correct nutrition to that, correct body maintenance to that. What happens? We basically have a chance to fight against it. Can we cure it? No. Can we get the body to work on it? Sure we can. Can we raise our immunity? Yes. I mean, that's what prehabilitation with laser does. Anyway, before I get totally excited and fall off of my chair, Sanna.
I have nothing to add to that, Rob. You and Trevor covered it all, and I really enjoyed working with it, because this is a really big field that actually can change a lot for the humanity. Yeah.
Okay, thanks for that, guys. I'm going to wrap up with one last question because I appreciate the patience of all of you, but it's been a topic that's generated a lot of interest and a lot of questions, and there's a lot of long answers as well. So if we can just go through this this last one, please. It's from Ferenc, who works for a company called
Simon, you have vanished.
Form in Hungary. You have mentioned so-called universal protocol for vagus nerve regulation stimulation using EBRL. Quick one to that one.
Oh, yeah, I forgot about that.
Oh, is anything happening, guys?
Yeah, just reading it because you were breaking up, Trevor. Sorry, Simon, you were breaking up. Basically, I think a lot of this we've covered already at the beginning. I think the one thing we didn't cover is the keloid scar. I think issues with things like that. A lot of time with scars like that, you're going to be able to change the color. You're going to cause a little bit of reduction in terms of the inflammation of the tissue with that. But really, that's a surgical revision. And then once you've done the surgical revision, you can follow that through with the laser. I know it's something that we surgically revise quite a lot. And we've used the lasers on afterwards, and it's been quite successful. But I think I've tried treating them without a surgical intervention. And for me, it hasn't been really successful. So the rest of the questions there I think have already been answered. That's the one that hasn't. Trevor, keloid scars, do you want to say anything about those?
Yeah, I haven't had, like, definitely with scars in general, but keloidal stuff is really tough. I mean, I will use that 8/16, 45, 363 setting on it. Keloids are, that's a tough one to, sometimes you can maybe mitigate or down the size of it a little bit, but complete resolution of that, I haven't had great success with that. With regards to vagal nerve, I get it. Like there's that element of, you'll hear different teachers talk where some will start at the brainstem base of the skull and then work their way down and around and all the way down to the stomach. That's great. That's a great way to do it. You do have left and right autonomic regulation too, so that can come into play. And actually, let me, Simon, if I will, because I know you got a lot of applied neurologists and chiropractors and stuff listening. You can also use those modalities for all the COVID stuff with regards to the different parts of your immune system, when you want them to be turned on and when you want them to be turned off. So let me oversimplify this to give you guys some good clinical nuggets. We need that initial inflammation cascade like we've all been talking about, but you have to be able to shut it off. Well, if you're fighting off like a common cold or something like that, your left brain is the bias for increasing that output of things like natural killer cells and TH response, like Th1 responses. And your midline cerebellum is involved with that as well too. So if I want to attack a cold, if you will, or something like that, I'm going to do like spinal adjustments, especially of the right side, to bias to left cortical midline integration. You can actually increase interleukin responses that way. Now with COVID, because we need more resolution, we want more right brain activation and non-midline. So I'm going to laser the right brain for resolution and shutting off the immune response, if you will. And my adjustments aren't going to be midline. I'm going to do more like left upper and lower extremity adjusting and whatnot to have more of a resolution component. So it's kind of a interesting little way you can do applied, chiropractic and other types of manual therapies in your laser bias as well too, depending on what you're trying to target for that. With the sensory processing stuff, what you were looking at, this again is one of the reasons I use the 1 Hertz frequency, because it not only creates nice interhemispheric communication and global communication for the brain, like we've been alluding to all day, to have the different parts of the brain be able to say, like especially your frontal system, you'll say, no, don't worry about that limbic system and things like that. But it also has to do with your sensory integration with the within the parietal system. So one more reason to use that 1 Hertz and the 10 Hertz for the resting digesting, like we've been talking about, like a 110 or 110 40 60, is that 1 Hertz is very effective with sensory processing. Now what we'll do is maybe take some of your other modalities that like the percussor or something along those lines, and do sensory stimulation and build them up to do different, like be able to differentiate between vibration and hot and cold, heavy blanket stuff, things like that, while we laser like the medial parietal lobe and you know, the ipsilateral vagus system and whatnot, to actually allow them to start to adapt to that type of sensory input. I'll hand it over.
No, that's a great response. Yeah, I mean, it's a perfect way to finish off actually with that response. Sanna, Rob, if you've got some little gems to share there, or feel free.
Like I think I said all I need to, really, or all I think I need to say on the COVID thing. I think really the most important thing with COVID is research tells us that its modus operandi is basically to create as much havoc and inflammation within the system as possible, and it causes vast amounts of upregulation and downregulation as well. And I think really once as we remove as much of the non-essential inflammation from the system as possible, then we can actually treat it. I think the important thing to remember is, like we said, you know, it's wrapped in a lipid bilayer more so than a lot of other viruses. These lasers are great for emulsifying and breaking down fat. So, you know, let's cut off some of its fuel supply. Let's reduce the inflammation that it needs in order to spread itself around, and basically the body can do it the rest, because we're not really looking to cure it. As I said, you know, we just want to bring the viral load down. And like once we get that viral load down, the body can take care of itself. Anyway, waffling again. Son.
We ended up talking about scars and ended up with COVID again. So I don't know if I'm going back to the scars, because I don't have any. I have any non-experience of keloid scars, but scars is really important for the brain, not because of how it looks, because it's how sensory drives motor inputs. So we can look at scars from another way, but I don't know if we're going to take it here now, if that was the question.
Yeah, another question for another time, I think. But, you know, guys, I think for most people, I hope they all agree that this webinar has been fantastic. I'd like to thank Trevor from over in Arizona there for coming on and coming off and coming on. You know, you run such a busy clinic up there, so it's very, you know, we very much appreciate your time.
My pleasure. Anytime. It's always good to see my buddies over in Europe, and I look forward to doing it again for you guys. So we'll take care of you all. Have a great day.
Thanks, Trevor. We'll get some seminars sorted. And again, Sanna, for your first one coming on, you know, seeing as though English isn't your first language, you did an absolutely fantastic job, and you speak better English than Rob and I. So I knew that you would lift your head up with that one. But
it's not my first language either.
Sorry, I forgot Gaelic's your first language, but thanks very much, guys. We try to do everything here with a sense of humor and you know, try not to get too stuffy. So thank you very much to the panel again. We'll get together and decide which topics to cover next. I think it's great having some, you know, some speakers. We've had, you know, Ireland, we've had America, we've had Sweden, we've had the UK on this call. So it's always good to hear different perspectives. So thanks for that. And if anybody has any further questions, you'll all receive an email after this webinar is finished with a questionnaire. Let us know and we'll get back to you as soon as we can. But up until then, sorry to take up your Wednesday evening. We hope you found it worthwhile, and until next time.
Take care.
Thank you. Until next time.
Bye-bye.
Bye.